With pulmonary valve stenosis, that means the pulmonary veins cannot empty into the left ventricle, right? So you get back pressure into the lungs. So you tend to have pulmonary venous congestion, and pregnancy makes it worse, right? Justin, why will pregnancy make it worse?
Because then you're increasing the preload.
Exactly, the volume.
Yeah.
General blood increase in blood volume with pregnancy. Okay. Now they tend to have chronic cough and hoarseness. Okay. And this is due to recurrent laryngeal nerve compression by the enlarged left atrium. The left atrium is in the back. It's when it gets enlarged, it compresses the recurrent laryngeal nerve, and then gives patients hoarseness. Thyroid will do the same thing. A thyroid enlargement, a goiter will do the same thing. All right. Lung cancer can do the same thing. Okay. So hoarseness is a pretty serious symptom if you see a patient that presents with it. Okay. Atrial fibrillation is very common because the atrial muscle is increased, right? And they tend to have thromboembolic phenomenon because of this atrial fibrillation. They tend to get pulmonary hemorrhage. That is a late manifestation. It's as a result of the venous distension, right? So when you have distended veins and fragile capillary beds, patient coughs, the capillaries rupture and they bleed into the lumen, and the blood comes out. Okay, so hemoptysis is a manifestation of mitral valve stenosis, but please remember, it's a late manifestation. It's not an early manifestation. And as you can tell, it gives you a diastolic murmur, so it will increase the intensity of S1, right? And then you have a right heart failure because of the pulmonary venous congestion that makes it difficult for the right ventricle to pump blood to the lungs because of the congestion, right? The lungs cannot empty into the left atrium because of the mitral stenosis, because the mitral stenosis prevents left atrium from emptying into the left ventricle. So if the lungs cannot empty into the left atrium, then the right ventricle cannot push anything through. So the right heart fails. Okay? And of course on EKG you always see left atrial enlargement, and echocardiogram you will see the stenosis. And I told you one important difference between EKG and echo is that with echo you can actually measure the tightness of the stenosis from the pressure gradient. Okay? And of course you really do cardiac cath. Atrial fibrillation is a big deal. You control it, we'll deal with that. Right? Indication for intervention: when the pulmonary pressure is above 50, you really have to do something, or your patient is symptomatic. What do? Balloon valvuloplasty is what you do all the time for all stenosis. Regurgitation you always have to replace. It is when valvuloplasty fails that we go to replacement. So that's mitral stenosis. I know I repeated myself. Now mitral regurgitation, the primary type is more common and is usually due to intrinsic valve disease. So mitral valve prolapse is a very common cause. Papillary muscle ischemia. You remember what the papillary muscles do, right?
Yeah.
They contract with the ventricle to increase the tension in the chordae tendineae to prevent the cusp from opening back up. So if you have a coronary artery disease in the territory of the papillary muscle, that muscle is not going to be able to contract. When that muscle is not able to contract, then it's not going to be able to increase the tension in the chordae tendineae, and that will lead to the opening back of the cusp into the left atrium. And I told you that is the reason if you go to in the coronary care unit, cardiologists listen to patients' heart every single day, sometimes more than once a day, especially when the patient has already ruled in for myocardial infarction, because you want to know which valve might be in trouble, because when that happens, many times it's a big emergency. So papillary muscle ischemia, infective endocarditis, ruptured chordae tendineae, right? If you infarct a papillary muscle, if the papillary muscle dies, it will lose its connection to the cardiac tendon. So the cusp becomes free. That's a big deal. Okay? Aromatic fever in developing countries. There are secondary causes, left ventricular failure and left ventricular dilatation. All right? Remember, I always told you that the cusp, they have fixed size. So when you dilate the chamber, you can actually pull them apart. They touch themselves and they close effectively for as long as the ventricular cavity is normal. If you begin to distend the ventricular cavity, you will pull them apart and you will create regurgitation. Okay? How does it present? Left heart failure. Softest one. Remember, because it gives you a systolic murmur, it will give you a softest one. Right? Okay. And because of the volume overload, you get an S3. Pulmonary hypertension, of course, from the volume, and right heart failure. Again, EKG will show LAE, LVH. Echo will show you the regurgitant jet. And if you're seeing it in somebody with multiple risk factors for coronary artery disease, you may want to do cardiac catheterization, because if you're going to go into somebody's chest, you better make sure you fix everything that needs to be fixed once. Okay? How do you treat this stuff? Most importantly, you do preload reduction because of the volume overload. Preload reduction. So you want to reduce the volume that is going into that left ventricle. More importantly, you do what is called afterload reduction. I want you to think. So the left ventricle is supposed to push blood only through the aorta, right? Now, if the mitral valve is leaking, that means the left ventricle will generate pressure and blood will go back into the left atrium and forward through the aorta. If you want more blood to go through the aorta, reduce the peripheral resistance in the aorta. That is the logic behind afterload reduction in mitral regurgitation, is to encourage forward flow by reducing the peripheral resistance in the aorta. Okay. And of course, because of the damage to the left ventricle, you want to assist with the remodeling and the healing of the left ventricle. So we always give ACE inhibitors, right, or ARBs. When would you do something about this? Whenever the forward ejection fraction is less than 60%. That is a bad situation. Or the left ventricular end systolic dilatation is more than 40 millimeters. I told you, I'm giving you this just to fulfill the books. I'm never going to ask you, I don't think anybody will ask you, when would you do intervention for mitral regurgitation in terms of echocardiographic parameters, unless you're going to be a cardiologist. Okay. And what do? You always repair or replace. You don't do, there is no valve, you don't do valvuloplasty for regurgitation. Okay, just one thing.
Do you know if the pants will ask anything?
If what?
If the pants, the certification says will ask
Pants?
Yeah.
Your board exam?
Yeah, will ask anything.
I have not seen them ask for that, but I won't ask you for this. I usually can't review my questions to make sure it's in line with what fans expect you to know. Okay, and you can do all the past questions you can. It's always a good idea. And I've not seen, in the ones I have seen, I've not seen them ask you for this. Even in internal medicine boards, yeah, they will ask you this rarely. I'm not going to be the one that will make a decision. It's the cardiologist. Why are you bothering me with that? All right, so let's talk about mitral valve prolapse. Mitral valve prolapse is basically when you have a congenital abnormality in the cusp. The cusp is bigger than the left ventricular cavity. Right? It's like oversized cusp. So you see, this is a normal left ventricle with the cusp, right? This is left ventricular chamber. This is blood. These are the cusp. You see how they meet themselves, right? And this is usually how it is. Nature makes room for a little bit of dilatation. So it is not with every, okay, think about it like this. Imagine that this thing I'm doing here, I'm not very flexible, is the left ventricle, okay? This is the front, this is the back. And these are my digits are the cusp, right, together. Under normal circumstances, they're like this, right? If something happens and the ventricle dilates a little bit, yeah, it will dilate and they will still be in touch. All right? Now, if it continues to dilate, then it pulls them apart. This is normal. There are times where the cusp is a little bit bigger than it should be. When it is bigger than it should be, this is what you get. It becomes redundant. Right? When it becomes redundant, instead of it flattening out in ventricular systole and becoming tight, it becomes floppy. It balloons into the left atrium. Instead of staying like this, it becomes like this. Now there is a difference between when it is like this and when it is like this. You know that pressure is force per unit area, right? Force per unit area, that is pressure. So when it is like this, the area is wider, less pressure, right? When it balloons, the area is smaller. So the same pressure will give you more force, right? Because of that ballooning, it pushes the cusp open and then creates a regurgitation. That ballooning gives you a click. That opening gives you a murmur. That is why mitral valve prolapse is called click murmur syndrome. You all understand the pathophysiology for the click and for the murmur, right? You have to understand that pressure is force per unit area. Okay? Pressure is force over area. If you decrease area, you increase pressure. Okay? So when the cusp is straight, there's more area. When it becomes balloon, it becomes less area. When there is less area, there is more force. That force will push it back into the atrium and opens it. That ballooning will give you a click that you will hear on auscultation. And when it opens back up, it now gives you the murmur of regurgitation because of the turbulence associated with it. Okay? So let's talk about mitral valve prolapse. It is called a degenerative mitral valve disease. It's myxomatous degeneration of valve leaflets and cornea tendineae. It's usually idiopathic and is secondary to connective tissue diseases, most commonly with Marfan's and Ehlers-Danlos syndrome. It is generally asymptomatic. It's not something that a kid will be diagnosed with at birth. But occasionally in teenage years, he will present with non-specific signs and symptoms like chest pain, palpitation. They can even faint or feel dizzy. You have a systolic click with or without a systolic murmur, depending on the stage at which the patient is presenting. If the patient is presenting early, it might just be the click you will hear. When the patient is presenting late, you will hear the click and the murmur. Okay? Now, this right here is extremely important for you to understand. The murmur increases as LV volume decreases with decreased preload. So think about it. Remember I told you it's a redundant flappy cusp, right? When is it likely to be more redundant? Is it when the ventricle is distended or contracted? When it is contracted. That is why when you have decreased preload, as in sitting up or standing up, or in Valsalva maneuver, the murmur of mitral valve prolapse increases. Okay? And it decreases whenever the left ventricular volume increases. Like when you have hand grip. Hand grip increases the peripheral resistance. And because it increases the peripheral resistance, it reduces the left ventricular ejection. When it decreases the left ventricular ejection, it increases the left ventricular end systolic volume. Keep the volume, the left ventricular volume a little bit more dilated, and it will decrease the murmur because it decreases the redundancy. If you remember everything I've told you about murmurs and preload and afterload, you will notice that is the exact opposite of most murmurs. So it is extremely important for you to remember this very well. Remember that the murmurs of mitral valve prolapse increases with standing and sitting or Valsalva maneuvers and decreases with LV volume increases. Because remember, under normal circumstances, increased flow should give you increased turbulence and increase the murmur. That is true, except in mitral valve prolapse. Okay, so many times in exam, they just tell you what the murmur does with sitting and standing. And if it is the opposite of what you expect, you begin to think this is more likely mitral valve prolapse. Okay? Diagnosis is echocardiography. I don't even know why we waste time diagnosing this stuff. We don't really treat it, we treat the symptoms. Okay? Now, so that is all about, we're done with our valves. Let me now talk to you about, generally speaking, we give antithrombotic therapy whenever we replace or even repair heart valves. It's extremely important for you to know that this is an evolving field. This slide looks really complicated. It is not a very smart diagram, but because I saw it in Lancet, and I thought people in Lancet are smart people. But I don't like this diagram. It's very redundant.
What's Lancet?
Lancet Journal. Yeah, right? So, it's very redundant. Because basically let's go through it. I mean, see, if you replace somebody's heart valve with a mechanical valve, you're going to need to give them vitamin K antagonist. Right? And that vitamin K antagonist is going to be for life. That is all there is. Mechanical heart valve, whether you do mitral valve replacement, aortic valve replacement, with risk factor or without risk factor, you do exactly the same thing. You do vitamin K antagonist and aspirin for life. That is all. Why don't you just put one bullet there, say mechanical valve replacement, vitamin K analog, and aspirin for life. And if for any reason the patient has to have a surgery, they have to have tonsillectomy, appendectomy, then you can discontinue the vitamin K analog and give them a bridging anticoagulation with either unfractionated heparin or low molecular weight heparin, Lovenox. Okay, that is a bridge to keep the blood a little thinner while they go for this surgery, and immediately after the surgery, they go back on their vitamin K antagonist. Okay, the only time you don't need to do that is if it is aortic valve replacement, because the risk of thromboembolism for some reason is lower. So that is all this big old deal thing is. Everything here is the same thing. Why do you keep repeating yourself, the boring people, right? So that's why I say it's not a particularly good thing. And why is the color coding? Well, that's why I told you it's an evolving area. When we have settled and we know there is evidence that this is the right thing to do, this is why it is class 1. When we're still studying it, trying to figure out is this really the best thing to do? Then it becomes class 2A, class 2B, class 3 evidence, depending on the strength of the evidence. So you can see that for mechanical heart valve, we're pretty certain that everybody needs to be on antithrombotic with both anticoagulant and antiplatelets, okay, together. Now, if we use a bioprosthetic valve instead of the mechanical valve, bioprosthetic is from pig or other animals, right? If you replace mitral valve, you're supposed to give the vitamin A analog for the first 3 months and then aspirin. If it was aortic valve, exactly the same thing, again followed with aspirin. Whenever you do the transcatheter aortic valve replacement, because there is minimal disruption and scarring, you might get away with just clopidogrel and aspirin, okay, for the first 6 months, okay? So, what is the bottom line here? The bottom line is on this side. If you know that your patient has had a valve replacement, many times in primary care, the surgeons, they don't send you good discharge summaries. So many times you don't even know what the heck happened, right? And they will send your patient home on something. If they sent your patient home on warfarin and aspirin, and they told the patient you're going to take this for life, you know that patient had a mechanical valve, right? If they give your patient only 3 months of life, you suspect that that patient probably had a bioprosthetic. That's why it's good to know these things, because in primary care practice, you don't get the kind of courtesy that you need, except you work within a place like Kaiser or UCLA Health, where the medical record is available to you. You can tell, you can read whatever they did, right? But in the community here, you just have to kind of figure out what is going on to make sure your patient gets the best they can. Okay. You're clear with this?
Yeah.
Excellent. All right. So I have some questions here. Christian, which of the following is associated with ventricular volume overload?
D.
D, good. Crystal, what is the most likely diagnosis in an asymptomatic 26-year-old female with a history of Marfan syndrome on a routine visit for preconception evaluation? On physical examination, she's 5'10", weighs 162 pounds. She has an arm span of 74 inches. Why am I giving you all this information?
Marfan's.
Okay. The vital signs are within normal limit. JVP is normal, that is jugular venous pressure. There is a grade 3 to 6 late peaking systolic murmur and a mid systolic click. I mean, what picture am I painting here?
Mitral valve prolapse.
Exactly. He says the murmur decreases with hand grip and increases with valsalva maneuver. The first half sound and the second half sound are normal. He said the lungs are clear to auscultation. So what is the diagnosis here?
E.
Mitral valve regurgitation. So this is the way the questions come. It looks complicated, but the truth is, if you know what you know, once they begin to throw things at you that looks like Marfan syndrome, and they're telling you arm span and height, and they're talking click, they've almost given you the answer. If you don't know it, you don't know it. But if you know it, you know, or there is enough clue in that question to tell me if mitral valve and mitral valve regurgitation. Okay?
Sorry, is it
Mitral valve.
mitral valve prolapse? You said
Yeah, but the prolapse clinically presents with regurgitation.
So you have mitral valve prolapse.
Oh, sorry. Why? You see, this is why when you guys Yeah. What is the answer?
Mitral valve.
Mitral valve.
What is the answer? Think again.
D.
You say D. Okay, how many of you say D? If you say D, raise your right hand.
Well,
Okay, so Christian said D, right? How many of you say E? The very first thing I told you under the mitral valve lecture was usually asymptomatic, right? Mitral valve prolapse is usually asymptomatic. The question is asking you, what is the most likely diagnosis? What you're looking at here is mitral valve prolapse presenting as mitral regurgitation, right? But the question is, this is a very bad question, right? Okay, but I can defend it, but I won't defend it. I think it's a bad question. Because the truth is, I give you a click. If I give you a click, the answer cannot be mitral regurgitation, right? I give you Marfan syndrome. The answer cannot be simple mitral regurgitation because there is a lot more causes of mitral regurgitation than Marfan. So in any exam, whenever there is a more specific answer, something that is more specific to the clinical scenario they have painted, that is the answer. You see, in this case, it looks like D and E are similar, but the true answer really is E. Because E covers everything here. You don't see Marfan's and mitral regurgitation are not necessarily associated. You don't see clicks, you don't hear clicks in all regurgitation. And not all regurgitation murmurs will decrease with hand grip. Only mitral valve prolapse regurgitation will decrease with hand grip. So there is a lot more specific detail that relates to mitral valve prolapse than mitral regurgitation by itself. Okay, I mean, it looks like a bad question, but I think it really tests your clinical reasoning. You know, and I forgot why I put it there like that. So I won't change it. You just need to know. These are the kind of things people will test you with. And I probably will, now that I've taught it. Okay? Which of the following is associated with ventricular pressure overload?
D.
D? Did you say D? What is the answer? Lars, what is the answer?
A.
They say A? Pressure overload. Why is this confusing?
I
You
thought
said
it was D, but
Yeah, I said, but did anybody
You
say
just asked
A?
this
you said
question.
D and you said you didn't like the answer.
I didn't hear it. You know, I told you, either you read it all of the above,
Yeah.
or suddenly D as in dog.
We said D.
Yes, I didn't hear the D. Okay, D and B sound similar. All right, please. Okay, I'm glad you got that. All right, Kiara, what is the most likely diagnosis in an asymptomatic 45-year-old male hypertensive diabetic smoker with a history of recurrent upper GI bleed ×2 in the past 10 years, who presents with chest pain and exertion? There is no associated shortness of breath or palpitation. Physical examination, blood pressure, pulse. He has a slow rising, low volume peripheral pulse. The cardiac impulse is shifted and sustained. First heart sound is normal, but the second heart sound is single and soft. And there is a systolic murmur loudest at the left upper sternal border. What picture is this? Thank you, aortic stenosis. That's it, right? I need you, see, let me tell you something. If at the end of the day, all of you can recognize clues from questions, my job is done. There is a lot of, and believe you me, this is not enough. Many times in the questions that I've seen, they throw everything at you. You just have to be able to understand it. See, when they say the guy has upper GI bleed, come on, you know that upper GI bleed and aortic stenosis because of the pressure and the von Willebrand factor disruption we talked about, right? So they do get. GI bleeds. Unlike mitral stenosis, they get lung bleeds, not GI bleed, right? Okay, and then it tells you that the pulse is low volume and slow rising. That means the left ventricular output is impaired. So the pulse, enough blood is not coming out per beat. So the pulse is low volume and it's slow rising. Now it tells you that the cardiac impulse is shifted and sustained. Usually the cardiac impulse is in the mid-clavicular line in the left fifth intercostal space, right? That's where it's supposed to be. If it's shifted, that means the left ventricle is enlarged. That is the way they paint the picture of left ventricular hypertrophy for you, right? When it is a right ventricular hypertrophy, they will tell you the patient has a right parasternal heave. So when you hear a right parasternal heave, that generally means the right ventricle is enlarged. When you hear that the apex is shifted and sustained, that means it's the left ventricular hypertrophy. Okay? You should learn all this in physical diagnosis. I hope you will. Now, you see, this is the way I would ask you this if I was to ask you. So, Ali, which one of the following is an indication for intervention in an asymptomatic patient with mitral regurgitation? Thank you, thank you. Usually I will, if you, look, I'm telling you now, if I ever ask you that question on what the indication is for intervention in any valvular disorder, the answer would always be all of the above. Okay. So what is the most likely diagnosis in an asymptomatic 25-year-old male with a history of a heart murmur on a routine visit for an annual wellness exam? Vital signs are within normal limits. Physical examination is essentially unremarkable, with the exception of a soft S1 and a fixed wide splitting of S2. There is a grade 3 to 6 systolic murmur at the left upper sternal border and another systolic murmur at the apex. The cardiac impulse is well placed and normal. There is no left parasternal heave. EKG showed left ventricular hypertrophy and left atrial enlargement. It should be E. Oh, no. Left axis deviation. Left axis deviation. You'll figure it out. But we can still come to a diagnosis with that.
Oh, okay.
What? So basically, you know, this is some either. Tell me what the answer is.
I know it's ASD.
Good. It's ASD, but which one? And you must tell me why it is whichever one you pick. It's ASD because of the wide splitting of S2, right? Yeah. Okay. Do you expect to have a 3 to 6 systolic murmur at the left upper sternal border and another systolic murmur at the apex in straightforward ASD? Which ASD will give you? First of all, tell me, what do you think is responsible for these systolic murmurs?
Some turbulence.
Huh?
Some turbulence.
Turbulence as a result of what? Valvular disorders or flow?
Yeah.
One of them is flow. Which one do you think is flow?
This question is so loaded.
One of the systolic murmur is flow. So when there is ASD, where will the increased flow take place? When there is ASD, blood is going to come from the left atrium to the right. So the right ventricle is volume overloaded. So if there will be any functional flow murmur, it's going to be a pulmonary flow murmur, right? Right?
Yeah.
So that is why I gave you that systolic murmur at the left upper sternal border. Right? Remember, the left upper sternal border is the pulmonary valve area. Right? Now, how do you explain this 4/6 systolic murmur at the apex? The apex is your mitral area. If you have a systolic murmur in the mitral area, what is that? Especially when I also tell you that S1 is soft.
Systolic.
So when you have a soft S1 and a systolic murmur in the mitral area, what are we talking about? Mitral regurgitation, which ASD is possibly associated or usually associated with mitral regurgitation? Premium. Exactly. So that is the way the question will come. You have to know everything. Right? Because everything will be needed in practice. You don't want to confuse an ordinary ASD with an ostium premium type. So you know that if this was a sinus venosus type, all you will have is just fixed wide splitting of S2. That's it. And you may actually have the systolic murmur. Please remember, have you guys done cardiac exam in physical diagnosis?
No.
Oh, okay. All right. Okay. This is where you need to know that aortic valve space is in the right upper sternal border. Pulmonic valve space is in the left upper sternal border. Tricuspid is in the left lower sternal border, and the mitral valve is in the mid-clavicular line at the apex of the heart. So once you are able to locate those areas, you'll be able to make better sense of this question. Because I know the reason for the confusion was that you really couldn't understand what I meant by left upper sternal border. Left upper sternal border is another way of saying pulmonary area. Okay. If I had said that, I'm sure all of you would have understood the question. So it made it a little bit more complicated. But okay. Now I won't, you shouldn't, that is not a reason to flunk this exam. What I want you to know is that ASD of the premium type is usually associated with mitral valve problems. It's the only one. That is the reason I mentioned that in the class, remember? Okay, moving on. Hung. Oh, yes, you. Which of the following is an indication for intervention in an asymptomatic patient with aortic regurgitation?
D for all of
Lost. You're next. No, Tarika. What is the most appropriate next step in the evaluation of a 45-year-old male, smoker, history of heart murmur, who presents with a 6-week history of exogenous chest pain with palpitation and near syncope? Vital signs are normal except for this blood pressure of 160/70. Physical examination is significant for collapsing radial pulse and a positive Quincke sign on the nail bed capillaries. First heart sound is normal. Second heart sound is loud with an S3 gallop. There is a loud diastolic murmur and another soft diastolic rumble at the apex. What do you think is going on here? The question is, first, in order for you to figure out what the next step is, you have to tell me what do you think is going on. What is your diagnosis? Or what are you suspecting? He's 45. He has chest pain. He has palpitation. Why doesn't my stuff show on this thing? Anybody knows why? Why doesn't my pointer show on this particular screen? Oh, it does show. It's not. It's less visible. All right. So, what is anything? What information do you gain from the blood pressure? What is unusual about that blood pressure? It's high, but it's not just high, right? There is more to it.
It's wide.
The pulse pressure is unreasonably wide, right? Normal pulse pressure is is less than 30, right? What is the pulse pressure here? It's twice that, right? So something is wrong. Which valvular disorder will give you a wide pulse pressure? Aortic regurgitation, right? Good. So that is already telling you. Then I'm not telling you the radial pulse is collapsing. Oh yes, that is the rapid volume shift of aortic regurgitation will give you that collapsing pulse. It will give you that quick sign as well. Well, if it's aortic regurgitation, then it makes sense that S2 will be soft, right? And it gives you a diastolic rumble. Both of these are diastolic murmurs. So in aortic regurgitation, what would you do? You think now, Terika, that this is aortic regurgitation. You agree? So when you see a patient in clinic in Burundi with aortic regurgitation, what would you recommend? What would you like to know immediately? Electrocardiography. How many people agree with her? You agree with electrocardiography? What would you get from electrocardiography?
Just the rhythm, electrical pacing.
Electrical.
Yeah, well, okay, so you get the electrocardiography and then you see LVH and LAE, so what?
You need all of them.
Actually,
You need echo?
the most echo. What you want to know once you see that, what exactly you want to, how tight is this? How bad is it? Does this patient need, do I need to write a letter to the US Embassy and send this patient to St. Jude's or one of those pediatric that do charity work all over the world, right? You want to know, does this patient need surgery now? And the only thing that can give you that is really echocardiogram. Okay, EKG will show you, yes, it's straining the left ventricle and the left atrium, but then so what? That is not, you already think that could be the case because of the volume of the load. You could tell that. What you can't tell is how tight or how bad is that ventricular damage, and that can come only from the echocardiogram. Okay, this is not a good question because all of the above made it like, but you know the truth. I think it's not a bad question because there is no reason whatsoever for 24-hour Holter monitoring in this patient. Why would you do 24-hour Holter monitoring? What's the point? The only way you would think about 24-hour Holter monitoring is if you got fooled by that palpitation and near syncope. If you recognize palpitation and near syncope as potential symptoms of aortic regurgitation, you will not look for Holter monitoring. What would Holter give you? We won't give you any information as far as the diagnosis is concerned. Not even in the management. What would you do? Why would you do Holter? So, Holter monitoring is definitely, you all know what Holter monitoring is, right?
Yeah.
Holter monitoring is EKG, ambulatory EKG, basically. Just take one lead and record the patient for 24 hours, sometimes for 72 hours, right? Is looking for arrhythmias. If you think the patient has a hidden arrhythmia that comes and goes, then you put them on Holter monitoring to monitor the cardiac rhythm of the heart. Okay, that will become clearer before the end of the day because we're going to start EKG and stuff. You had a question?
Yeah, I have a question. So in the slide you were telling us to do an EKG and an echo. EKG and the echo. So are you saying usually if the person has aortic regurgitation, you want us to do EKG first? Is that?
Okay.
That's why I was thinking.
If you have, the question is, what is the most appropriate next step? That question, next step, should tell you right there and then that you really can't be all of the above. What is the most appropriate next step? Right? Right? So if you read the question carefully, it's asking for the next step. EKG, you do in your office. Echo, you obtain approval to do. 24-hour Holter, you obtain approval to do. You cannot do all of them at the same time, right? To start with. Now, secondly, yes, electrocardiography, if you want to go from, there is a principle in healthcare that you always go from the least expensive to the most expensive. I subscribe for a minute to that argument. So let's do the least expensive. You do electrocardiography and then you would then do echo. But then the answer is now here. All of the above. You know all of the above cannot be because 24-hour Holter monitoring is not indicated here. You only have to choose between echo and electrocardiography. Which one will give you the information that will impact your therapeutic decision? The test that will influence your decision for treatment is the right answer all the time. If that test will not change your mind either way, it is not essential. And what I'm telling you is not just for this question. It is the way it is in medicine. It is the way they will expect you to think in exam. These days, we test your cost effectiveness as a provider. You don't order everything. You only order what you need to make a decision. If the test does not really influence your decision, and one does, the one that influences your decision is the right answer. EKG in this case, yeah, will show you some stuff, but there are things you already suspect the patient may have. It won't change what you will do, but echo will, because all of the indications for intervention are going to be obtained only on echocardiogram. You got it? Okay. All right. Which one of the following is associated with the giant A wave in the jugular vein? Stanley. Giant A wave in the jugular vein.
Tricuspid stenosis.
This is tricuspid stenosis. I want you to think a little bit, well, you probably don't know AV dissociation, but I will describe each of these for you and then tell me whether you think they will work. Do you know what AV dissociation is? Okay, under normal circumstances, this is the atria, these are the ventricles. This is how it works. It's in sequence, the atria contract, ventricle contract. When you have AV dissociation, they are no longer in sequence.
Yeah.
So what will happen at times when the atrium and the ventricle, the right atrium and the right ventricle contract at exactly the same time? Exactly. The atrial valve will close when the right atrium is, the tricuspid valve will be closed when the right atrium is contracting.
Yeah.
So there will be nowhere for the blood to go.
Yeah.
So what will happen? It will go back in the neck. So I'll give you a giant A wave. Right?
Yeah.
So the answer really is all of the above. Okay? Yeah. That will become clear in the next few hours. Okay?
What's ventricular pacing?
Ventricular pacing is when somebody has their AV node is dead. You now have to put a battery on the outside and put the lead of the battery into the ventricle to shock the ventricle. So it's basically you're applying the electricity from outside of the body with a pacemaker, right? And the lead is in the ventricle. All those pacemakers, you can divide them into two, either atrial pacing or ventricular pacing. If the patient has a functional AV node, you pace the atria. So you shock the atrium, and the atrium can get shocked and transmit the shock through the AV node to the ventricles. If the AV node is dead, then you go straight and shock the ventricle. So it's called LV pacing. Okay. Sometimes you shock both. It's called dual pacing. Well, we get there. All right. This question is really for Stephanie. What is the most appropriate antithrombotic option for an otherwise healthy 65-year-old girl intensive whose aortic valve just got replaced with mechanical prosthesis?
D.
Huh?
E.
E. Good. So this is a very common pattern for my exam. I'm introducing you to it now. All right. So we're going to start with Maureen. So you're going to tell me one and match over there. Left to right shunt. What is it? Left to right shunt.
Is it G?
Now, Gia, give me a word. What is the answer?
She said Gary.
Gary or Google?
Gary.
Okay,
Gary.
yes. That's the answer. So it's a left to right shunt. Then, right to left shunt. We're going this way.
Oh, okay. Oh.
Is that also
Right to left shunt.
a ventricular septal defect?
She just said
Oh, wait.
ventricular,
Wait, right.
right? That's what she said,
Yeah.
right? So right now the question is a right to left shunt. What is it here?
J?
Thank you. Good. Next.
What did you say?
J. Jungle Latin. Asamaga syndrome.
Right to left. What can it be? Tricuspid effusion.
Why can't it be what?
Tricuspid effusion.
Right to left shunt. Tricuspid atresia. You're right. Yeah, it could be tricuspid atresia.
Don't you only get the right to left and Eisenmenger where it's like...
Yeah. Tricuspid atresia will also give you a right to left shunt. Eisenmenger will also give you a right to left. It's also a right to left shunt. So, given what we know now, Tolu, what do you think is the answer? Merge H and J together to make it make sense.
So I'll do number 2 for H. And
You will do number 3 for J. What is that? Was that what you said?
Number 2 for H, for tricuspid.
Okay, so you would write the left shunt for tricuspid atresia.
Yes, and I'll do reverse left to right shunt for Eisenmenger syndrome.
And that is the way to do it. This slide needs a lot more time, and I'm a little pressed. I'm going to skip it, okay? Because I don't want just answers. I need you to be able to derive the answers. And right now, I'm not able to walk you through the process. And I don't want you panicking, and this is supposed to be very simple. It's just that we need time to
Decide.
the way I will teach this, the way I've done this with the other classes is we take left to right shunt and we go through all of the options here and make sure that we exclude every single one of them and pick the one that is the answer. Usually we spend about 10 minutes. I really have to go now. I can't do this now. But I can, if you like, I can post it. Okay. Okay. I'll post it. So you guys can now do your exercise and I will do it. And then we'll go over it together. Okay? Yeah. I'm in trouble today. I don't even know how we got out of time so much. Alright, infective endocarditis is an infection in the innermost layer of the heart in people with congenital and valvular heart disease. The way it works is whenever there is turbulence, there is friction. Whenever there is friction, there will be inflammation. Whenever there is inflammation, then the integrity of the endocardium is breached. You will be fine with a breached endocardium if there is no infective material in the blood. But if, for any reason, you get a transient bacteremia, where you have bacteria in the blood, for whatever reason, that single bacterium can now lodge into that inflamed area and set up a home. And that is what infective endocarditis really is. That is how it happens. Okay? And basically, this is what the heart looks like. If you take it out and you slice it open, all of this is pus. Okay? And like I just told you, you need two things for this to happen. You need to have that breach and that inflammation going on. And then you need to have bacteria in the blood. The way you get bacteria in the blood is you have a breach of the mucous membrane. It could be from trauma, it could be from whatever. And that mucous membrane breach could be in the mouth, it could be in the gut, it does not matter. All you need to have a breach in the mucous membrane, get bacteria in the blood, and have a breach in the endothelium of the heart, and the two together give you colonization, and then you get all this vegetation. Now, when you have a non-bacterial thrombotic endocarditis, in other words, you have breached the endothelium of the heart, you have created inflammation, and you're already getting fibrin deposited, but no bacteria is colonizing it yet. That is what is called a marantic endocarditis. That is, it is sterile. It is there, but it is sterile. Marantic. The reason you need to know about it is because, yes, it is sterile, but it can give you stroke. Okay, it can give you tiny strokes and emboli, which is what we fear the most about endocarditis, because endocarditis leaks pocket of pus into the circulation, and that can go into the brain, can go into the eyes, cause major problem, multiple abscesses all over the place. So look at the predisposition. In order for you to get endocarditis, you need a high-risk patient and a high-risk procedure. Okay, remember those two. High-risk patient and a high-risk procedure. Who is your high-risk patient? The high-risk patient is somebody with a history of infective endocarditis. It's happened to them before. Somebody that carries a prosthetic heart valve. Somebody with a history of cyanotic, mark my word, cyanotic congenital heart disease, or a cyanotic congenital heart disease within 6 months of repair, or a residual defect around the repair. So a cyanotic congenital heart disease by itself is not high risk. But if that heart disease has just been recently fixed, or the fixing is not perfect, then that acyanotic congenital heart disease makes the patient high risk. Notice, just because somebody has had a heart transplant does not make them high risk. Only when there is a valvular disease in that transplanted heart. Okay? Two things that they often test is, because heart transplant sounds like a big deal, you would think it's a high risk, but it's not. Okay, and you will get this in practice all the time. Dentists will always tell you, clear this patient for surgery. He has a history of heart transplant. That does not make him high risk. If he doesn't have any murmurs, he doesn't have any history of infective endocarditis, and he does not have a prosthetic heart valve, he's not high risk. What are the high-risk procedures? They're usually dental procedures, respiratory procedures, and skin and soft tissue procedures. Pay attention to the dental procedures. Not all dental procedures are high-risk procedures. If the dental procedure involves the manipulation of gingival tissue and perforation of an infected oral mucosa, replacing dental devices or routine injection through clean and intact mucosa is not high risk. If you're going to take out the dentures and you don't have any root abscess, that is not a high risk procedure. But if you have a root abscess, for which now you're going to get a root canal, then you're going to be walking through infected tissue. That is a high risk procedure. Respiratory procedures is high risk only if it is invasive. Either because they're going to take a biopsy, or they're going to do bougie, in which case they will disrupt the respiratory lining. Then that becomes high risk. Routine bronchoscopy without biopsy is not high risk. Right? So it is extremely important for you to have a good understanding of what is the interventionist intends to do. Okay? It's not enough to say, oh, he's going to have a procedure done. What procedure? Exactly what is the procedure? And of course, skin and soft tissue procedures, if uninfected skin and soft tissue, yes, you better make sure you have endocarditis prophylaxis. Pay attention. Gastrointestinal and genitourinary tract procedures do not predispose to infective endocarditis. So colonoscopy, cystoscopy, upper GI, endoscopy, those are not high-risk procedures. Okay? How does it present? Exactly what I just told you. It presents with clots, throwing infective clot all over the body. So the patient will present in the eyes with subconjunctival hemorrhage 2 to 5% of the times. They have varying heart murmurs, conduction disorders, sometimes heart failure. They can have hematuria. They have Osler's node, which are painful. They have petechial rashes. They can have strokes. In the eyes, when you look in the eyes, you can see rod spots. And when you do ophthalmology, you will learn more about that. You can have petechial hemorrhages on the mucous membrane. Poor dentition is not a manifestation but a risk. But I know why they put it here as a manifestation. You don't get poor dentition from endocarditis, no. But poor dentition predisposes you to endocarditis. You got that? Okay. Systemic emboli, digital clubbing, and splinter hemorrhages in the nail beds. There are some cutaneous manifestations of endocarditis you need to be aware of. Jane-Wayne lesion and Osler's node, they are both manifestations. They look alike. And many times in practice, you really have to know how to tell them apart. Not that it matters, but people just get this intellectual orgasm from testing this kind of things. I don't do it, but I've seen it in your exam, and they always make sure I test it. I don't know why. Jane-Wayne lesions are non-tender and they don't blanch, but they're blanching because they're vascular lesions. Osler's node are tender and they are non-blanching. Just know that. However you remember it, it doesn't matter to me. I want you to know that Jane-Wayne is non-tender and is blanching. Osler's are tender and they are non-blanching. Blanching means if you put pressure, it doesn't become pale. Okay? This is what splinter hemorrhages look like in the nail bed. And this is what your subconjunctival hemorrhage looks like. If you do ophthalmoscopy or you have retinal camera and you take a picture of the patient's retina, you will see these rust spots. These are microemboli. Okay? How do you diagnose endocarditis? Thank Duke University. Because as you can see, the manifestation is a lot, right? So they divided them into two groups, major criteria and minor criteria. If you get a positive blood culture, that is the major criteria. In somebody with echocardiographic evidence of vegetation or abscess of prosthesis dehiscence, and you have a valvular regurgitation murmur. These are major. So basically what you need here is for somebody to have a regurgitation murmur, evidence of infection like a fever that will prompt you to do blood culture, right? And will prompt you to do an echocardiogram. Those are the three major criteria. You have to have at least one of them. And then everything else is minor criteria. History of drug use, diabetes, patient carries an indwelling venous catheter, they are dialysis patient, right? They have vascular phenomena like all those lesions we talked about, Osler's node, they have fever, positive blood culture. So how do you then use these two criteria? In order for you to make a diagnosis of endocarditis, you have to have two major criteria or one major criteria plus any three minor criteria or five minor criteria. This is the weakest of them all. Okay? That five minor criteria is the weakest of them all. I have seen them and the patient didn't have endocarditis. Okay? So that's why I told you that, yeah, this is what it is right now, but in practice, you must make sure you have the major criteria on the patient. Okay? Now, see what, if you miss the diagnosis of endocarditis, this is how you will know it. If your diagnosis, your patient recovers from endocarditis after 4 days on antibiotics, they never had endocarditis. Okay? So you don't, this is not an easy diagnosis. Patient don't recover as fast. Okay? You understand? Are you clear with this? Okay. How do you treat this stuff?
So about the blood culture at the bottom, it said blood culture of quantitative organism is not meeting major criteria. So I have particular.
Say it again.
The blood culture quantity for organisms not meeting major criteria. So are we supposed to know the organisms that meet major criteria then?
Yes, generally the microbiologist, the lab will tell you. There are HACCP organisms, a bunch of stuff that are usually associated. Remember, the organism that will cause this, okay, for instance, let me give you an example. If somebody had bronchoscopy and you culture E. coli in their blood, is it likely that that is coming from the bronchoscopy? It's unlikely, right? So the organism that you culture from the blood has to be a resident of the area that was breached on the mucosa. That's what that is telling you. How do you treat this? You have to, in fact, usually what we do here is we don't wait for blood culture to return. We don't wait for the test result. We start the patient on empiric antibiotics. We draw the blood culture and start the patient antibiotics, and then we wait. Okay? And usually you use empiric coverage, vancomycin. You guys have done, did you do pharmacology?
Not yet.
Not yet? Oh, so anyway. So you don't know what vancomycin is? Okay, it's an antibiotic. Okay, good. And ceftriaxone. You always give both of them together. Then when you get the culture result, you will determine how you adjust that based on your culture result. For me, what is important is that you remember that if after your patient has been on antibiotic therapy and their blood culture continues to be positive, that is an intervention for you to send them for cardiac surgery. Because that means whatever bug you have there is not responding to antibiotics and the valve needs to be replaced. Okay? So indication for surgery in native valves is written there. I usually don't test this, but I think you should know it. I've seen a couple of questions. Patient with valvular stenosis or regurgitation resulting in heart failure, aortic or mitral valve. I want you to pay attention. What is the bottom line here? Pay attention to that ACC guideline. You see that the emphasis is on right-sided lesion. Left-sided lesion. If it's a mitral or aortic valve lesion, those are the high-risk ones. Because remember, if it's in the right side, it gets trapped in the lungs. It doesn't go all over the body. But when it's on the left side, it becomes very problematic. It can go anywhere in the body. So we pay more attention. We intervene sooner when it's on the left side. And that is what all of this is about. Okay? You don't make these decisions. It's the cardiologists and cardiovascular surgeons that make these decisions. All right? So, given everything I just told you, you now see why it is important to make sure that you prevent endocarditis. Prevent endocarditis for high-risk patients that are undergoing high-risk procedures. The standard is amoxicillin. If your patient, usually 60 minutes before the procedure, if your patient has to be NPO, meaning nothing by mouth, then you have to use ampicillin instead of amoxicillin. If they have allergy to penicillin, you can use azithromycin or clindamycin. If you suspect that the patient will be exposed to Staphylococcus aureus, in other words, it's an upper airway or oral procedure or skin, then you have to use cloxacillin or nafcillin, depending on whether your patient has to be NPO or not. If your patient has MRSA, that's a very bad Staph aureus, methicillin-resistant Staphylococcus aureus, you have to use vancomycin, okay, as prophylaxis. We use vancomycin for treating, but only with MRSA we do use vancomycin for prophylaxis, okay?
So you're saying, like, the patient has MRSA, and then you're going to give them a procedure, so that the risk of getting...
Exactly.
Okay.
So if somebody has a history of MRSA, and they are going for, and they have a heart murmur, and they have a history of MRSA because they were in the hospital for a long time, and you want to give them endocarditis prophylaxis, you have to use vancomycin. Okay. All right. Oh man, I am so out of time. I want to do these questions, but for Christ's sake, you guys, let's go through this quickly. For which of the following is endocarditis prophylaxis indicated? Vincent, for which of the following is endocarditis prophylaxis indicated? Let's go through each of these. I don't want to rush. I want to make sure you guys understand this. So, 46-year-old female with a history of mitral valve repair for mitral stenosis 2 years ago, now scheduled for tooth extraction. No. Good. 28-year-old male with a history of tetralogy of Fallot, scheduled to have the root canal for root abscess.
Yeah.
Good. That is the one that needs it.
Yeah.
Right? The 68-year-old male cardiac transplant patient with no abnormal physical finding, scheduled for perineal abscess, incision and drainage. Yeah, the procedure is high risk, but the patient is not. In order for you to need endocarditis prophylaxis, you must have a high-risk patient undergoing a high-risk procedure. All right? 38-year-old pregnant female with a history of mitral valve replacement, scheduled for an elective CS. That is not a high-risk patient. Right? Yeah, the patient is high-risk because she has a history of valve replacement, right? But she's going for elective CS. That is not a high-risk procedure. In order for you to need endocarditis prophylaxis, you have to be a high-risk patient going for a high-risk procedure. Okay? So which of the following is the most appropriate endocarditis prophylaxis? Christian, a regimen for a 78-year-old male with a prosthetic aortic valve scheduled for bronchoscopy and lung biopsy. The patient is going for bronchoscopy. For bronchoscopy, it needs to be NPO, right?
Yeah. So
okay. All right. So what is it? Thank you. Okay, the old class. We're just going to go through this one. I think it's the last one. Oh no. What is the best next step in the management of this 33-year-old female with a history of bicuspid aortic valve and aortic regurgitation, admitted 2 weeks ago for infective endocarditis? 2 out of 3 blood cultures were positive for Staph aureus, sensitive to oxacillin, and echocardiography demonstrated 12 millimeter vegetations on the aortic valve with mild regurgitation and normal left ventricular function on admission. Repeat blood cultures drawn 2 days ago is still positive for Staph aureus, sensitive to oxacillin in spite of 10 days IV oxacillin.
Okay.
A
You're going to change oxacillin to vancomycin?
is D, because you said it was.
Thank you. Heart valve surgery.
Oh yeah.
Because after these 10 days on antibiotics, she's still positive for the same bug with the same sensitivity. That means
It's not responding.
the only way that happens is when there is endocarditis and there is scarring that is protecting the bug underneath. And the only way to get rid of the bug is to get the valve out. Okay? For which of the following patient is endocarditis prophylaxis not indicated? Crystal. For which of the following patient is endocarditis prophylaxis not indicated? 44-year-old, so tell me here now. 44-year-old female recipient of a donor heart with a loud S1 and a systolic murmur scheduled for dental abscess drainage. Huh?
It's C, no?
That one need. Okay, good. 38-year-old male with a history of infective endocarditis scheduled for multiple teeth extraction.
Yes.
63-year-old female cardiac patient with a prosthetic mitral valve scheduled for routine colonoscopy.
No.
Good, thank you. Now you got it. I think I can thank you. Now, I want to give you guys 5 minutes break.
Yeah.
Where is Stephanie and Christian? All right, so left to right shunt. Is it pulmonary regurgitation? No. Aortic stenosis? No. Mitral regurgitation? Volume overload? Pressure overload? Microstenosis? Ventricular septal defect?
Yes.
Tricuspid atresia? Isomander? Good. Right to left shunt. Pulmonary stenosis? Aortic stenosis? Mitral regurgitation? Volume overload? Pressure overload? Microstenosis? Ventricular septal defect? Right to left shunt? Tricuspid atresia? Good. Aortic regurgitation? Isomander? Thank you. Pulmonary hypertension? Pulmonary regurgitation? What is the commonest cause of pulmonary regurgitation? Pulmonary regurgitation. Pulmonary hypertension is the commonest cause of pulmonary regurgitation. Remember I told you when the pressure in the lung is high, right? Exactly. So pulmonary hypertension is still associated with pulmonary regurgitation, right?
Yes.
Reverse left to right shunt is isomander,
Yes.
right? A loud first half sound, pulmonary regurgitation, aortic stenosis, answer me. Mitral regurgitation, volume overload, pressure overload, microstenosis.
Yes.
Good. Soft first half sound, mitral regurgitation, right?
Yes.
Loud second half sound, pulmonary regurgitation. Respond please.
No.
Aortic stenosis, mitral regurgitation, volume overload, pressure overload, microstenosis, ventricular septal defect, tricuspid atresia, aortic regurgitation.
Yes.
Good. Soft second half sound, you know that. Aortic stenosis, right? Third half sound, volume, and fourth half sound, pressure. Wow, okay. Any question? Okay. I just have to finish that. I feel like I didn't end the class well if I didn't do it. Because your midterm is in 2 classes, right?
After spring break.
After spring break.
No, midterm is before break.
No, that's after. It's the Monday after.
For Paul, yes.
Oh, okay. I don't want to file anything out. Okay, so we're going to talk about EKG. So this is the very, very rudimentary EKG. There will be another EKG in the summer. That is the real deal. So now we're just going to lay the groundwork. It is extremely important that for the next 60 minutes that you understand and you hear every single word that comes out of my mouth. I'm not going to kid around. Everything I say is going to be important in the next hour. You're all very familiar with cardiac action potential, right? How the heart muscles depolarizes spontaneously, right? You are familiar with the 4 phases. I've lost light on my stuff, so okay. So you're familiar with the 4 phases and the ionic fluxes associated with them, right? We don't need to repeat this. Do I need to do that? Good. And then what is important for you to know is that the heart muscle is a muscle like any other muscle. Its action potential is through the reflecting of the other, like a simple muscle action potential. The electrical activity of the heart is conducted by the body fluid through the body tissues to the body surface. Thank you. So that electrical activity we talked about, the depolarization and repolarization, they are actually electrical waves, and they are indeed connected. They get conducted to the body surface through the body tissues and body fluid. Okay? So basically, what an EKG machine is really a galvanometer. You all know what a galvanometer is, right? A galvanometer. How many of you guys did physics?
I did.
Okay. And you didn't do it?
Went downhill and then
So basically, a galvanometer is a device that detects current flow. So when current flows through any area, a galvanometer will detect it. Right? So basically, what an EKG, and it just tells you this is Ohm's law and the field, and it doesn't just flow. The current doesn't just flow anyway. Between the magnetic field and the current, there is Ohm's law that tells you in what direction the current will flow. You don't need to know anything about that. All you really need to know is that the EKG machine is nothing but a galvanometer. It detects current flow, right? So it uses galvanometer to record and amplify voltage differences between 2 electrodes on the body surface. So a galvanometer detects current flow, and in order for you to detect current flow is a vector, which means it has magnitude and it has direction, right? It's not, quantities are divided into scalar and vector quantities, right? So, how do I say that? You cannot, okay, if you're driving in your car, right, your speed is a measure, there's a quantity and there's a direction. You're traveling east at 60 miles an hour, right? So your speed is because when you look at your speedometer, you can look at your speed and know what your speed is. Your speed is not necessarily connected to your direction. It's just the rate at which your car is traveling. But if I start talking about the velocity of your car, then that means your speed in a specific direction. So speed is called a scalar quantity. Velocity is a vector, because not only does it have magnitude, it has a direction associated with that magnitude. Okay, so EKG machine, they use galvanometer to pick up those electrical activities from the heart, from the surface of the skin. And the EKG machine is not just a galvanometer, it also has a mechanism for amplifying those voltage differences so you can actually record it and see it. Okay? So bottom line here is all I need to know is EKG machine, basically a big galvanometer. That's what it is. So you see, when we look at an EKG, that action potential of the heart is picked up on the EKG, and it is that surface recording of the cardiac action potential that we call an EKG. Okay? So it's surface recording of the electrical activities of the heart. Formally, you will say the surface recording of the voltage difference created by the electrical activity of the heart between two electrodes on the body surface. And you notice in the previous slides, I said between two electrodes, because in order for you to find direction, you have to have two reference points. I cannot tell you north if I don't know what west is. I cannot tell you east unless I know what west is, right? So the galvanometer will tell you the flow of the current in a specific direction, and in order for it to do that, it needs two reference points. You need a point of origin and a point of destination. Now, those points that we use for reference are what we call the EKG leads. Okay? Those reference points are called EKG leads. So an EKG lead is a recording of the electrical activity of the heart from electrode placed at specific sites on the surface of the body. A standard EKG consists of recordings from 6 limb leads and 6 precordial leads. So a standard EKG will show you a dozen recordings. Six of them are from the precordial leads, that is chest leads, and 6 of them are from the limb leads. Okay? The limb leads, they record the frontal plane, that is top to bottom. Okay? The precordial leads record from the horizontal plane. In other words, you have leads that look at the heart and look at the heart like that. Okay? Remember, we are just picking the electrical activity of the heart. We want to pick it in all the different directions, right? And get as much information as we can. So it's extremely important for you to understand that the precordial leads, they look at the heart in the horizontal plane, front and back, and the limb leads top to bottom, right? So let me ask you, if I want to make a comment on the inferior surface of the heart, which lead will I look? Is it a precordial lead or a limb lead? A limb lead, exactly. If I want to see what is going on at the septum, which lead would I be looking at? Precordial, exactly. Good. So you get that orientation. Extremely important. My dean is submitting a grant, and she's been pestering me since 4 a.m. And now she's texting me, please allow me to respond to this. Yes, please. Okay, good. We got that right?
Really quick. It says the limb leads record from the frontal plane. Shouldn't it be front to back, not top to bottom?
Say it again?
The limb leads record from the frontal plane, so cut this way. Shouldn't that read front to back?
No, no. This is your horizontal. This is your, so this is your horizontal. I think horizontal, the yellow is horizontal, this is your frontal. Right? Yeah. It's the way it looks. That's why I use, you see this horizontal frontal plane can be confusing. Just remember top to bottom and front to back. Okay? Now, how do we place the leads? You place the limb leads on the right wrist, left wrist, right leg, and the left leg. It does not matter whether you put it at the wrist or at the shoulder. It does not affect the recording. Okay? Because sometimes you find diabetic patients that have been amputated, right? What you don't want to do is to put it at the right ankle and then the left hip. You can't do that. If somebody doesn't have the right leg, then you do the left and right hip, and the right and left shoulder, right? So it does not matter whether the lead is down here or up here. It does not matter, okay? So the EKG machine can designate any skin electrode, positive or negative, depending on the lead that is being recorded. So we put the leads, we apply the leads. The leads are just to pick up the currents. The machine will decide what is going to be positive or negative. In other words, the EKG machine can itself designate what is a positive versus a negative pole of that lead. In other words, you can set the EKG machine to say that, okay, the right lead will be positive, and positive means it's sensing the current coming towards it. Negative means it senses the current going away from it. Okay? So, the leads are just leads. None of them is permanently positive or negative. That's what I'm saying to you. They are just points, reference points. The machine can decide which one to designate positive or negative. Okay? So, because the limb leads, there are 6 of them, 3 of them are bipolar. In other words, they have 2 poles. One positive, one negative, right? Lead 1 measures the potential, the voltage difference between the left and the right arm relative, between the left and the right arm, period. Lead 1. Lead 2 depict the voltage difference between the right arm and the left leg. And lead 3 depicts the voltage difference between the left arm and the left leg. Notice the left leg is always the reference lead, the reference point. Although there is a lead on the right leg, that lead on the right leg is actually the ground. Okay, is the ground lead. Okay? This one, there is nothing to explain. You just have to know that is the way it is. Okay? Lead 1 is between the 2 arms. Lead 2 is between the right arm and the left leg. Okay? And lead 3 is between the left arm and the left leg.
What would you call the left leg again?
The left leg?
Yeah.
Lead 3.
The reference. Okay.
Left arm and the left leg, lead 3. So those red lines is what is telling you that is the direction. Okay? Yes. Good. So when you look at those leads, right? 1, 2, 3. And you put them together, this guy, William Einthoven, imagine that, okay, we have 3 leads. If you put them together, they actually form an imaginary inverted equilateral triangle. Equilateral triangle is a triangle with equal sides. Okay? Why is he doing this? Because we need to figure out a way to actually translate the electrical activity that we are recording from the skin into some mathematical number that gives us information about the heart. In order for us to do that, we have to make the heart the center of the equilateral triangle, right? Because remember, we are interested in the electrical activity of the heart because that electrical activity of the heart is coming from the muscles of the heart. And the health of the muscles of the heart will be reflected in that electrical activity. That's how we're measuring it. Okay? So this is the first phase, putting the three leads together into an equilateral triangle is called Itovin's triangle. And then the next thing that somebody did that was very interesting was that when you take the leads from the right arm, the left arm and the left leg, and you connect the lead, the three leads, to a single point on the galvanometer does not move. That means somehow the electrical activity coming from the heart, when you pick them up from the right lead, the right arm lead, left leg lead, and the left arm lead, and you put them on a point, all of the voltages sum up to 0. Okay? Are you with me? Yeah. It sounds like gibberish, but it is the basis for you to understand EKG. That was not something we expected. It was just discovered that, oh, if you sum up all the limb leads and you connect them to the terminal and the galvanometer, it sums up to 0. That then means that you can measure the voltage difference between any one of those limb leads relative to that 0 point. You see, for lead 1, you're measuring the voltage difference between the right arm and the left arm, right? But for lead 3, you're measuring left arm and the left leg. You need to have a way to standardize what you're looking at across those leads, right? You measure right and left arm. Yeah, okay, you got that. And then you now have another value from left arm and left leg. So what is the connection between left arm and left leg relative to right arm and left arm? We need to look for a way to compare the leads. So when it was discovered that if you put all the three leads together, you actually get 0, then that means we can now measure the voltage difference between that 0 point and the left arm and get what is the complete voltage difference between that reference point and the left arm, and using the same reference point compare it to the left leg, and we can get the absolute voltage difference between the reference point and the left leg. And now we can compare that voltage difference between the reference point and the left leg to the voltage difference between the reference point and the left arm. So it's a way of standardizing it. So when you compare the voltage difference between any of those limbs to that reference point, you now get the other three leads that are called the augmented limb leads. And I will explain to you why it is called the augmented limb leads. But in order for you to understand that, you need to understand first that V electrode, that point where everything is 0 on the limb leads. Okay? The voltages from the three limbs sum up to 0 when they are connected to a common terminal designated as the V electrode. I just explained that. So that common terminal can become a reference point for an exploring electrode when connected to the negative terminal of the galvanometer. So
that means if you just measure the voltage difference from
that reference point,
you get that number again, because that's the number for all of them.
That is the number for that particular limb, the difference between that reference point and that particular limb.
Oh, but it's not going to be the same number for all.
It's not going to be the same.
Oh.
It will be different, right? Yes, it will be different. Just hang with me for a minute. So let us put this into a mathematical relationship. So that lead, because now we have a common reference point, that exploring electrode is now, it doesn't need two leads anymore. We only need one lead. Okay? So if I put that lead in the right arm, it tells me what the voltage difference is between the right arm and that common lead. If I put it in the left leg, it tells me what the voltage difference is between the left leg and that common V electrode. So I don't need two point anymore to measure voltage difference since I have a common reference point, right? So that EKG, that lead that measures the voltage difference between any one limb and the reference point is now a unipolar lead because it's only one lead and it can tell the voltage difference. Okay? You understand that, right? So you understand the difference between a bipolar leads and a unipolar leads. They are all limb leads. Whereas one is measuring voltage difference across limbs, the other is measuring voltage difference between limbs and a particular reference point that is common to all the limb leads.
How do you find that reference point?
That reference point is found by connecting the leads from all the bipolar limb leads. You connect all of them, the positive end of them, to a common terminal. And we know that it sums up to 0. So it does not influence the voltage difference we get from the unipolar leads. Are you with me? Okay. So let us see. Let us look at it mathematically. This is not where you're supposed to have trouble. So maybe I'm not explaining something right. So ask me questions. So it's important that you understand this, yes.
Can you go over again the difference between bipolar and unipolar?
The electrical activity of the heart is a vector. It has magnitude and it has direction. In order for you to appreciate direction, you need 2 reference points. So the bipolar limb leads, they give you that electrical activity of the heart between the 2 reference points, positive and negative, for right arm and left arm, lead 1, right arm and left leg, lead 2, left arm and left leg, lead 3. Right. And I said that it turns out that when you connect all the limb leads to one terminal, it sums up to 0. That now means that, okay, so you can actually measure the voltage difference from any one limb using that 0 reference point. So you don't need 2 leads. You can have only one lead and still be able to pick up on the direction of the heart. The lead that does that are called unipolar leads. Okay? Good. Now, let us look at the unipolar lead mathematically. So you measure the voltage difference between the exploring electrode placed on a limb and a common terminal, right? Mathematically, what you're really recording is, if you put it in the right arm, what you're recording is the voltage difference between the right arm and all the 3 leads together, right? Mathematically speaking. Because all of this is what add up to 0. Remember? Right? If you put it on the left arm, what you're actually measuring is this, right? If you put it on the left leg, what you're actually measuring is this. It turns out that because left leg is included in this bracket, and the left arm is included in this bracket, and the right arm is included in this bracket, it affects the quantity of that voltage difference. Okay? Even though that is a true representation, the resulting voltage differences at the right arm and the left arm and the left leg are significantly reduced because voltages at the reference limbs are included in the common terminal. So somebody figured out that, okay, why don't you eliminate if you're measuring the voltage difference between the right arm and the V0 electrode, let us not include the right arm in the bracket. We eliminate it. When they did that, it increases the voltage difference by more than 50%. So it increases the magnitude, allows it to be easier to detect both the magnitude and direction. That is when it was now called augmented limb lead. Okay, so when the limb, right, for instance, so when it's measuring the right arm, we took out the right arm from the bracket. When it's against the left arm, we took out the left arm from the bracket. When it's against the left leg, we took out the left leg from the bracket. That helps us to increase, to amplify the voltage difference by more than 50%, making it easier to measure. Okay? So what is the bottom line of everything that I'm telling you right now? Before I go here, let me just say this. Did all of you understand everything I just said so far? Okay, let me just give you the gist. The basic gist is there are precordial leads that look at the heart from front to back. There are limb leads that look at the heart from top to bottom. There are two types of limb leads. There are those that use two leads that are bipolar, right? And there are those that use unipolar leads that are just one polar leads. The ones that measure that are bipolar leads are called lead 1 because it measures the voltage difference between the right arm and the left arm. Lead 2 because it measures the voltage difference between the right arm and the left leg. And lead 3 because it measures the voltage difference between the left arm and the left leg. The ones that are unipolar leads that measure the voltage difference between the right arm and that zero-sum electrode is called AVR. It's a limb lead, but it's a unipolar lead. And the one that measures the voltage difference between the left arm and that V0 electrode is called AVL. So it tells you what the voltage difference is between the left arm and that reference point. And then the one that measures the voltage difference between the left leg and that reference point is called AVF. Okay? Now, how does that look? Let us put them together. So you see, AVF measures the difference between the left foot and that unipolar and that zero-sum electrode. AVL does the same thing. AVR does the same thing. Right? Are you all with me?
Yes.
Good. Is there anyone in the class now that does not understand what we're talking about? Please speak up, please. It's extremely important that you speak up. So you know what unipolar leads are, you know what bipolar leads are, you understand the isorange triangles, because now I'm going to put the unipolar leads within the isorange triangle, and it's going to look a little bit more complicated, but it is not as complicated as it looks. Yes.
I'm confused about the augmentation and then there's the regular before you did augmentation. The math-wise it looks exactly the same. Why is augmentation?
What do you mean it looks the same?
Like how for augmentation you took out the right arm.
Yeah, from inside the bracket.
Yeah. So why does it give you an increase in 50%?
Because think about it. You are calculating a difference between a number x and a sum of another set of numbers that include x. So you are somehow minimizing the difference because you are including right arm inside that equation. Mm-hmm. This is very mathematical, right? So by eliminating right arm from this particular equation, the difference becomes higher because let's put numbers to it. Everything here adds up to 0, mm-hmm. right? So let's say this is minus that, let me not complicate about this. Everything here adds up to 0, and there is an absolute number here. And the amount you get here depends on the difference between everything here and whatever is here. When you include right arm in here, you are minimizing the difference because you are including what you're trying to subtract from the sum of what you're subtracting from. Am I making sense? Yeah. You by including right arm inside this equation, you are minimizing this difference. By eliminating right arm from that equation, you're going to make this difference wider. Does it? I don't know if that help.
Yeah, a little.
Okay.
I feel like she confuses because technically the number would be bigger if you had the right arm. If you put right arm plus left arm plus left leg,
number would be bigger.
The number would be bigger minus that right arm. That's why I think the confusion is, right?
No,
that's
no.
What you're saying?
What you're forgetting is that everything adds up to 0. When you take out the, let me tell you the truth. When you take out everything adds up to 0. when you take out the right arm from here, technically speaking, it's no longer 0, right? It's negative. That's why the difference is larger. Nobody would tell you that, but that really is the mathematical reasoning behind it. Because it is mathematically incorrect, we don't talk about it like that. Okay? So we use the word augmentation. So in a way, it's like, we don't care how we do it. This is not mathematics. We just want to be able to record the electrical activity of the heart in sufficient quantity to be able to analyze it. That's all we want to do. We don't care too much about the mathematical accuracy. Okay, so by eliminating, because remember, I keep telling you that I'm measuring the right arm against the V0 electrode. But by definition, the V0 electrode is truly a V0 electrode only when it is a sum of all of them. When you eliminate one, technically speaking, it's really not a V0 anymore. That is why you got that increased scale, the 50% augmentation. And we're okay with that because we are not interested in the mathematics of it. It is the ability to get the electrical differences amplified, recorded, and analyzed that we're interested in. Okay? Nobody had asked me that before. Alright, so now so this is what you see. You see AVF, 0 point, AVF, AVL, AVR. So now, and it tells you what it's measuring, right? Ignore this, you will understand that later. So now, let us look at all the 6 limb leads together. If you look at all the 6 limb leads together, you find out that lead 1 forms this plane right here, lead 2 forms this plane right here, lead 3 forms this plane right here, AVL is this one, AVR is this one, AVF is this one, right? All the leads together. Now, that is clear, right?
Yeah.
Is there anyone in this class that does not understand this diagram? Everybody understand this, 100%. Good. Now let's make the heart the center of the matter. So if you separate, if you move lead 2, I want to tell you what I'm trying to do here. This is an equilateral triangle, right? And these are all different leads. Is there a way to rearrange this to make the heart the center? So we take our equilateral triangle right here. Let us move lead 2 and lead 3 and lead 1, have them intersect as have a common intersect. When you do that, you end up with this. Right? So this is your lead 2. We only moved it from being a triangle and putting it in the center. We rearrange all these lines to give them a common center. Right? So basically I'm taking the lines of derivation of the 3 standard limb leads in the ectopic triangle and I'm rearranging them to make them bisect one another instead of forming an equilateral triangle. Why am I doing this? Because I'm interested in the heart. Remember that. My interest is in the heart. I'm not really interested in the voltage difference between the right arm and the right leg or the right left arm. That is not what I'm interested in. I'm interested in how is the electrical activity from the heart spreading through the surface. So somehow I need to be able to make those leads measure that electrical activity from a common point. In order for me to do that, I have to bring all of them, make them bisect themselves and give them a common center. Right? If I do that, are you seeing what I'm seeing here? If I do that and I put my unipolar limb leads in there, I have translated everything into a circle with quadrants. Right? Because this is my lead 1, right? This is my lead 2, this is my lead 3, this is my AVR, this is my AVL, this is my AVF. All I need right now is to put a circle right here and I have a degree, 360. And because I have 360 degree, now I can begin to divide all this into quadrants and be able to tell you precisely in what direction is the wave traveling on the body surface from the heart. Did you see how we got, all we wanted to do is be able to measure it. We need to be able to measure it precisely. Right? So do you see how all the leads, because in the EKG you just put AVL, lead 1, AVR, yada. You need to know why are we doing what we're doing. All we're trying to do here is make the heart the center. Right? So that all these leads can occupy different quadrants in a circle around the heart. Are you all with me? Excellent. Now if we do that, this is now, because we have put all of them in a circle now, we can actually begin to tell which lead is looking at what side of the heart. Right? So because lead 3, AVF, and lead 2, they are looking from the bottom. Their positive pole is below the heart. They give us information about the inferior surface of the heart. So they are called inferior leads. Okay? And because AVL and lead 1, they look at the heart from the side, they are called lateral leads. Okay? Okay. Let me just recap to make sure you're still with me. So now we took the limb leads, right? We have the unipolar and we have the bipolar, right? The unipolar leads, they formed at first the equilateral triangle, right? We rearranged them to give them a common center, and on that we imposed the unipolar leads. That gives us a circle with the heart at the center. And because we're able to do that, we can actually begin to compute the quadrants between the different leads. And because we're able to compute the quadrants, we are more able to detect what is this lead really looking at within the context of the quadrant. We can now say, okay, lead AVF, lead 3 and lead 2, they are more looking from the bottom of the heart. So those are the inferior leads. And AVL and lead 1 are looking more from the side. They are the lateral leads. Okay? So what I want you to think about this lead from now on is think about them like cameras. Cameras. Remember, we describe them as positive. Only the positive poles are used. Okay? Only the positive poles are used, because that is what you want to see. You want to see how is the electrical activity of the heart traveling. When is it traveling towards that positive pole? Okay, because when it is traveling towards that pole, it will give you a positive reflection. When it is traveling away from that pole, it will give you a negative reflection. The galvanometer will register that direction like that. Okay, excellent. So that is all you need to know about limb leads, right? So how many sets of limb leads are there? Altogether, 2 sets. How many leads are there? 6. 3 bipolar and 3 unipolar limb leads, right? In all EKG, there are a dozen leads, right? 6 limb leads and 6 precordial leads, right? The limb leads are divided into 2 groups, unipolar and bipolar, right? Good. Now that is all you need to know about limb leads. Let's talk about precordial leads. Precordial leads, this is how we place them. We place them on the right side of the sternum, left side of the sternum, in the 4th intercostal space, and then go down. Then you do V5, then you find out the midpoint between V3 and V5, and that is your V4. And then in the lateral axillary line, all of this you should do in diagnostic class, how you place the leads and stuff like that. I don't want to waste too much time about it. It is described here. V1, V2, V3, V4, V5, V6. There are 6 precordial leads, okay? They look at the heart from front to back. Now, precordial chest leads, they depict the voltage difference between their location and that common terminal lead we talked about, okay? So each one of these is actually a unipolar lead measuring that voltage difference between its own location and that reference electrode, the V0 electrode that we talked about in the augmented limb leads, right? Okay. Since the voltage at the common terminal is 0, the precordial chest leads depict the actual voltage at their respective location. Now, so let us look at the way the R wave behaves in the precordial leads. So look at the recording from V1. This first wave is the P wave. This is called the QRS wave, and this is the T wave. This positive deflection is an R wave. See what happens? The R wave is very small in V1, right? It increases a little bit in V2, right? It becomes almost equal in V3, becomes actually equal in V4, it becomes predominantly positive in V5 and positive in V6. There is a reason why that QRS changes configuration like that. Because you see what happens is when the electrical impulse gets into the bundle of His and the right and left bundle, the first part of the heart that gets depolarized is the endocardial surface of the septum on the left side, right? So the septum gets depolarized first. So the waves move from the inside of the left ventricle through the septum towards the right side of the septum. So V1 sees, and V1 is here, right? It sees the wave coming towards it in the septum. So it gives you V1 and V2, they give you, that leads you R. Because remember, at the same time, the left ventricle is, actually there is something I forgot to tell you that I think will make this clear. No. You will not understand it now. I will explain it later, what I'm about to say. What I need you to pay attention to here is I want you to notice that the R wave increases down from V1 to V6. The R wave increases from V1 to V6. There is a reason why that is the case. It has to do with the sequence of depolarization. And I will explain that when you're more likely to get it. Right now, all I need you to know is R wave increases down from V1 to V6. And that R wave increase amplitude is called R wave progression. Okay? Very important. You must remember that, and you must look for it on every EKG. Look for R wave progression. Okay? And there is a reason why it is like that. But we'll talk about it later. So let us look at the heart at the center of the precordial leads. You see that V1 and V2, they are recorded over the right side of the heart, right? So they tell you more about the activities of the right, right? V3 is on the right side of the septum. V4 is on the left side of the septum. And V5 and V6, they are looking over the left ventricle, right? Is this confusing? Good. Good. Now, let us put everything together, both the precordial leads and the limb leads. So this is what it looks like. The heart is right here. ABL is looking at it from this side. ABR is looking at it from this side. ABF is looking at it from under. Lead 1 is looking at it from this side. Always the positive pole, okay? Lead 2 is looking at it from here. And lead 3 is looking at it from here. So you have to view these leads as cameras that you are put to detect the electrical activity of the heart. And look at the V leads. So at any time when you're recording an EKG, all these 12 leads are on the patient. And each one will give you a recording. And that recording is a reflection of the movement of the heart. Generally speaking, now you will understand this. Generally speaking, because the ventricles are thicker than the atria, the vector of the heart is always downwards. Okay, because remember, those electrical activity, they come from the myocardial cells, right? Because the ventricles are thicker, they have more cells than the atria. If you add all of them together and average it, it tends to be downwards, right? Because the ventricles are bigger. It tends to be leftwards because the left ventricle is thicker than the right ventricles. So the electrical axis of the heart is down and left. Okay? That is why we have to come up with a way to detect it. Okay? So now let's talk about that. What I just described is the mean electrical vector. So, we're going to read this together because I want you to understand this. The waves of depolarization and repolarization, they spread from the cardiomyocyte in many different directions at the same time, and they create these small electrical currents. Okay? These small individual electrical currents are known as instantaneous vectors. Okay? The average of all the instantaneous vectors is known as the mean electrical vector. So the mean electrical vector represents the average of all the individual vectors between the depolarizing and repolarizing cardiomyocyte. It is the mean electrical vector that is detected and depicted by the recording electrode. And the direction of the vector relative to the polarity of the electrode determines the direction and amplitude of deflection. Okay, so what am I saying? The heart is made up of heart cells. Each cell is depolarizing and repolarizing, generating its own instantaneous current. All of that current that travel together in one direction, they merge, and we pick them up on the surface of the skin. What the leads are detecting are not those individual instantaneous current. No, they are detecting the mean of the depolarizing and repolarizing wave from all the cells. Okay? And depending on how that mean electrical vector is traveling relative to the positive pole of that electrode, the deflection can be positive or it can be negative. Okay? So, if the mean electrical vector is traveling towards AVF, AVF will show a positive deflection. If it's traveling away from AVF, it will show a negative deflection. Okay? You got that? Excellent. This is the most difficult half of this class. So if you're with me so far, I hope you're really with me. This one you're looking like we're in the wilderness. Okay, so let me give you a little bit more information. So you see, yes?
You said towards AVF was positive and the other way was negative?
Yeah, if it's traveling, if the mean electrical vector of the heart, which is the sum of all those instantaneous vectors, is traveling toward the positive pole of any lead, the deflection in that lead will be positive. If it's traveling away from it, it will be negative. It will become clear on this particular slide. You know, I was trying to explain to you earlier that whenever the impulse gets through the bundle branches, right bundle and left bundle, the first part of the heart, the lower heart, the ventricles that get depolarized is the septum. The waves go from the left side towards the right side through the septum. If you look at lead 2, lead 2 is looking at the heart from this. Remember, the lead 2 is between right arm and the left foot, right? So it's looking at the heart from this side. So because the mean electrical vector of the heart is traveling from left to right, lead 2 will record it as a negative wave. So it will go down. Immediately after the septal repolarization, the next thing that happens is the depolarization of the free wall of the ventricles. Right? So the depolarization wave spreads to both ventricles at the same time. Now stop writing and listen. Lead 2 will record a positive deflection because now the waves are traveling towards it. Right? Can somebody tell me how will the fact that the waves are traveling at the same time away from lead 2 in the right ventricle, why is it that the lead 2 does not register the fact that the waves are traveling away from it through the right ventricle?
The mean?
Huh? Lead 2 is going to show a positive deflection because, yes, it's looking at the left ventricle and the waves are traveling towards it. But at the same time, the waves are traveling away from it.
It's not grabbing that snapshot.
Huh?
It's not grabbing that picture.
It's not grabbing the picture. That is one way to look at it. Hear what they say?
I thought I was reading, isn't it the south of all the...
Yeah, the mean.
Yeah, it's the mean. It's the mean. Exactly, it's the mean. So don't come on. I mean, you're away.
More is traveling towards lead 2 than is going away. So
Why? Why is more traveling towards lead 2? Because the left ventricle is thicker. You see, because the left ventricle is thicker than the right, its own mean electrical vector is bigger. So it submerges the negative of the right ventricle depolarization. So that's why lead 2 will show you a positive deflection, right? And then when the waves are now traveling up away from lead 2, it gives you that downward deflection. And then when the last part of the ventricle to get depolarized is actually the base of the left ventricle, that completes, he now sees it as a negative deflection going away from it, right? Do you see, the point of this slide is to show you that the way the EKG waves look in any one lead depends on the way the mean electrical vector is traveling relative to the positive pole of that lead. Do you need to understand why that particular lead has that configuration? No, you don't need to know the underpinnings. All you need to know is that, generally speaking, the EKG configuration in any one lead is determined by the relative direction of the mean electrical vector relative to that lead. And that is the point, the only point I want to make with this. EKG is not supposed to be this complicated, but I need you to understand why things are the way they are. Because I don't know where you find yourself. You need to understand. It is not everywhere in the world that they have EKG that interpret itself. There are some EKG machines that don't interpret. And you have to know why things are the way they are. Okay? Everybody with me so far? Excellent. So now that you have understood how things are, now let us go back to what is real. This is an EKG. So the atria, they have their electrical activity, right? So the green line, electrical activity. And that atrial electrical activity is followed immediately by the ventricular activity, right? Right? So in the heart, this is what is happening. The atrial cells are depolarizing, and they are followed immediately by the purple ventricular depolarization, right? You notice that as the atrial depolarizes, the atrial depolarization is followed immediately by the ventricular depolarization, which means that the ventricular depolarization is taking place at the same time as atrial repolarization. Do you see why it's confusing? All these electrical activities are going on at the same time.
Could you repeat that?
But the fact that ventricular depolarization follows atrial depolarization almost immediately means that atrial repolarization is taking place at the same time as ventricular depolarization. That is just for your information. What I need you to know is that this atrial activity on the EKG is represented by the PQ interval. On the EKG, you have a P wave and you have a PR interval. That interval between P and Q is what is called the PQ interval. Maybe there's something I need to tell you before we even go any further. The first wave on the EKG is called the P wave. They represent atrial electrical activity. Okay? The next configuration or wave on the EKG is a series of waves that are combined together. When waves are combined together, we don't call them waves, we call them complexes. Right? So the first wave on the EKG is a P wave. It reflects atrial activity. The next deflection is a series of waves combined together that we call the QRS complex. And that QRS complex is composed of the Q wave, the R wave, and the S wave. You don't see all the three of them at the same time, but generally you see two. Depending on which lead you're looking at, you could see QR or you could see RS. It depends on which lead you're seeing. But there are three of them. You don't see three of them in any one lead altogether. The QRS complex is usually followed by the T wave. Okay? So, I said the first wave you see on the EKG is the P wave, right? And the P wave is followed by the Q wave. The distance between the P wave and the Q wave, if you measure it from the end of the P wave to the beginning of the Q wave, is called the PR interval. If you measure it from the beginning of the P to the beginning of the Q, is called the PQ interval. I'm telling you that that PQ interval is a reflection of the atrial electrical activity. And the QRS the Q wave is the first negative deflection after a PR interval. Okay? Stop and listen. The Q wave is the first negative deflection after the PR interval. The R wave is the first positive deflection after the PR interval. So if you are looking at an EKG and you see a P wave and you see this, that means this is P wave, this is R wave, right? And this is T wave. But say you look at another lead and you see this. That means this is P wave, this is Q wave, this is R wave, this is R wave, this is S wave. So it's always QRS. For the beginning, determines what the subsequent waves are called. You understand what I'm saying? It's called a QRS complex because it consists of a Q wave, an R wave, and S wave. You don't see all the three of them at the same time. The only one that is defined is Q wave, is the first negative wave after the PR interval, and it's supposed to be followed by definition by an R wave. So if this is Q, this is got to be R. The R wave is the first positive deflection after the PR interval. So by definition, if this is R wave, this has got to be S. Okay? You understand it now, right?
Yeah.
Good. So the QRS complex, they represent ventricular depolarization, and the T wave actually correspond to ventricular repolarization. That is what the waves represent on the EKG. Okay? Everybody good? So now you know the EKG wave, the P wave, and you know the QRS T waves, right? So, one of the things that you will discover when you're looking at an EKG that we'd like for you to know is the mean electrical axis of the heart. The mean electrical axis of the heart is the overall direction of the mean electrical vector. It is defined only in the frontal plane. Okay? So if I ask you what is the axis of the heart, in other words, in what direction is the majority of the electrical activity of the heart traveling? That's what I'm asking you. Okay? It is called mean electrical axis. It can be defined only in the frontal plane. Right? Only in the limb leads. The chest lead, precordial leads cannot tell you that. Okay? It can be determined for P, so you can determine the P wave axis, QRS axis, or the T wave axis. It is driven by the cardiac chamber with the most muscle mass. So it is downwards because the ventricles have greater muscle mass than the atria. It is leftwards because the left ventricle has greater muscle mass than the right ventricle. Hence, the most important and the most frequently referenced mean electrical axis is that of the QRS complex. So if I tell me the axis of that heart, what I'm asking you to tell me is tell me what the axis of the QRS is. Tell me where the waves of the ventricular depolarization, what is their overall direction. And there is a way to detect that from the EKG. Alright, so how do we determine that? Do you see how now everything makes sense, right? Look at lead 2, look at lead 3, look at ADL, look at ADR, look at ABF, all nicely put into a circle, and now we have quadrants, right? Above, negative, below, positive. So we can actually say that the heart is between positive 120 to negative 30. We can actually put mathematical symbols on it. We can measure it. You see, we couldn't do this if we didn't have those leads and rearrange them the way we did. Okay? So the whole point for putting all those leads in a circle is to be able to determine where the mean electrical axis of the heart is. So we use the information provided by the limb leads to determine the position of the QRS axis. That is what we do. Okay? Everybody with me? Good. Now this is just background. So now this is what it is. What is the normal QRS axis? It is downwards and it's to the left. So generally it lies between 0 and 90 degrees. So now you understand, if I tell you the electrical axis of the heart is between 0 and 90 degrees, you know exactly what I'm talking about. Okay? So the normal axis of the heart is between 0 and 90. Okay? When it is more than negative 30, definitely left axis deviation. When it is more than 120, right axis deviation. But generally you want it to be between 0 and positive 90. Okay? Now let's see. How do you determine that from the EKG? It's very simple. Yes?
So the negative 30 to 90 wouldn't be considered normal axis?
No, 0 to 90 is normal axis, really. Okay? 0 to 90 is what it should be, the ideal. Okay? How do you determine that from an EKG? It's very simple. In order to determine the electrical axis of the heart from an EKG, you only need to look in two places. You look in lead 1 and you look in AVF. That's it. If your EKG QRS complex is predominantly negative in both lead 1 and lead AVF, that means your axis is indeterminate. You know why it's indeterminate? Because that means the heart, you cannot tell how it got to this quadrant. It could have gotten to this quadrant through an extreme left axis deviation or an extreme right axis deviation. You don't know. Once it is in this axis, the lead will be negative in 1 and AVF. You describe that axis as indeterminate because it could be an extreme right or an extreme left axis deviation. Everybody clear with me? Excellent. Now, if the QRS is positive in lead 1 and negative in AVF, that is a left axis deviation. Because that means it is actually between 0 and negative 90. That is not normal. That is what is called a left axis deviation. It's negative. Right? When it is positive in AVF and negative in 1, it's called a right axis deviation. Okay? When it is normal, it's supposed to be positive in both 1 and AVF. And this makes sense if you go back to this thing right here. Because it's supposed to be 0 to 90. So if it is negative in AVL and AVF, that means it is in this area here. All those numbers that are 0 to 9, there are two ways to look at this. You can focus on 0 to 90 degrees, 150, 180, negative 90, or just remember that if it is negative in AVF, normal is supposed to be positive in both 1 and AVF. And remember that lead 1 is in the arm, right arm and left arm, right? So if it is not up in both of them, that means it's normal on the right and normal on the left. If it is down in AVF, because AVF is left foot, right? That means it's left axis deviation. It's abnormal in AVF, that means left axis deviation, because AVF is measuring from left foot, right? I'm just teaching you how to take a look and make sense of what you're looking at immediately. If it is abnormal in lead 1, because lead 1 is looking at the right arm and right and left arm, if it's abnormal there, that means it's a right axis deviation. Okay? The abnormality, pinch the abnormality to the lead, but you have to know what that lead is measuring. Okay? So to make this like really easy, Maureen, so tell me, is this a normal or abnormal axis? This is lead 1, this is lead 2, this is lead 3, this is AVR, this is AVL, this is AVF, this is V1, V2, V3, V4, V5, V6. My first question to you is, among these 12 leads, by the way, don't get confused. These are lines that separate AVR from V1. These lines separate V4 from V1. These lines separate V5 from V2. So basically you have only 3 complexes. So my first question to you, Maureen, is these 12 leads, EKG, what information do you really need to tell me what the axis is?
1 and AVF.
Thank you. So looking at 1 and AVF, is the axis normal or abnormal? Exactly. So that's how you just look at an EKG and say normal axis. Right?
Can you point it out?
Huh?
Can you point out where it would link?
This is lead 1.
So
This is the
that
QRS.
will-
Is positive. QRS is positive in lead 1. And it's positive in ABF. So if it's positive in ABF and lead 1, that's normal. Right? Right? Good. So Bradley, my question is there QRS deviation here? The answer is yes or no? Yes? Is there QRS deviation? Yes? Did you say yes? Why did you say yes?
ABF is negative.
Thank you. Say it again.
It goes up and down.
Say it again.
It goes up and down. One is positive, one is negative.
So which one is it? Which one is it?
Okay, so lead 1 is positive.
Lead 1 is positive.
ABF.
ABF is negative. So what kind of axis deviation is this?
Left axis.
Thank you. So on this EKG, there is a left axis deviation. Okay? Right? Everybody cool with this?
Yeah.
All right. So what are the things that can cause left axis deviation? We have the left bundle branch block. If you have the left anterior fascicular block, if you have an inferior wall MI, if you have Wolff-Parkinson-White syndrome with a right-sided accessory pathway, if you have abdominal distension as in pregnancy, ascites, or truncal obesity, or if you have atrial septal defect of ostium premium type, remember that, or you have an artificial cardiac pacing. All of this you should be able to figure out why it will give you left axis deviation. Think about it. If somebody is pregnant, their pregnancy, baby will push on the heart, right? Right. So instead of being downwards and leftwards, it will be upwards, right? Because the pregnancy will push the heart upward. If somebody has massive ascites, it can affect the axis of the heart. Why is it important for you to know this? Because sometimes somebody will show an EKG. They say this is the EKG of your patient. Well, you have not seen the patient. If the patient has massive ascites and you see left axis deviation, you don't need to walk them up for left axis deviation. That left axis deviation could be due to the ascites. All right? So these are the causes, and you must know this. But don't worry about this list. As we go forward, we'll look at a lot of EKG and come up with differential diagnosis with history. This list will stick by itself. You know, just know that these are some of the causes of left axis deviation. All right. So now, what is going on here, Johnston? Is there axis deviation?
Yes.
What kind is it?
It's the right.
Thank you. That's all I need to know right now. Recognize axis deviation on EKG when you see it. All right? Y'all good with that? Good. Moving on. And these are the causes of right axis deviation. Look at it. Right bundle branch block, right ventricular hypertrophy. Oh, by the way, I need to tell you something. Do you think that left ventricular hypertrophy will shift the heart? Will shift the axis of the heart? Would left ventricular hypertrophy shift the axis of the heart? Because you see, right ventricular hypertrophy will shift it. If you have a right ventricular hypertrophy, the axis of the heart will shift to the right. You can have a right axis deviation. But my question is, should you have, or do you think it's logical to expect left ventricular hypertrophy to shift the axis of the heart?
No.
Thank you. Why wouldn't it? Vinny? Because it is the left ventricle that determines the normal axis of the heart. So if the left ventricle becomes hypertrophied, all it can do is to make the axis of the heart more normal. It cannot shift it. Many people don't understand that. You pick up a lot of textbooks and you will see left ventricular hypertrophy as a cause of left axis deviation. It's not true. Left ventricular hypertrophy cannot shift the axis of the heart because the normal axis of the heart is towards the left ventricle. Okay? The reason I said that is because right ventricular hypertrophy, bless you, right ventricular hypertrophy will shift the axis of the heart, but left ventricular hypertrophy will not. Okay? Again, Wolff Parkinson White with a left-sided accessory pathway and all that. Okay? So now, somebody tell me this. Chrissy, is there a KRS axis deviation here? Or should I just say, is it normal? Is the axis normal? Okay, what is wrong with it? Wendy? So if they're both negative, what does that mean? It's indeterminate. So the axis in this EKG is indeterminate, right? So now I've shown you examples of the right axis, a left axis, a normal axis, and an indeterminate axis. Moving on. What are the causes of indeterminate axis? Extreme left, extreme right, lead transposition. So whenever you see indeterminate axis, you want to make sure that your MA did not confuse the leads. Because if they plug the left lead on the right and plug the right on the left, your axis will be screwed up. And I will teach you how to determine whether there is lead switch on EKG as we go forward. But pay attention, hyperkalemia, emphysema. Emphysema is distended lungs and can distort the heart configuration of EKG. All right, moving on. So now let's talk about something that is a little. Now, are you all with me so far? Okay, now we're going a little bit deeper into this. You know EKG, right? You connect the patient. We've talked about the leads. Let's talk a little bit about the machine. EKG is recorded with a moving paper, right? The paper moves and the machine records as the paper moves. That paper is traveling at 25 millimeters per second. Okay? Why do we need to put the paper at a specific speed? Because that paper is ruled, right? It's a ruled paper. If we can make that paper travel at a specific speed, then we can assign time values to each of the ruling on the paper, right? So on the EKG, there are big squares and there are little squares, right? The little squares are 1 millimeter and the big squares are 5 millimeters, right? So if the paper is traveling at 25 millimeters per second, that means there are 5 big squares in every second, right? And that means each big square is 0.2 seconds, right? Which is about 200 milliseconds, right? And that means each small square is 0.04 seconds. Everybody with me? Good, huh? Did you understand it? You want me to repeat it?
No.
You got it? Okay, you don't have to calculate it. You just need to know it. Okay? I will teach you how to look at it and know it is or it isn't. Because what is the point of all this? We need to be able to measure how long did it take the impulse to travel from the atria to the ventricle through the PR interval. In order for us to measure the PR interval, we must have time value for the small boxes and the big boxes, right? That is why the paper had to be ruled in millimeters, small boxes, and 5 millimeters, big boxes. And since we know it travels at 25 millimeters per second, that means each big box is 0.2 seconds and each small box is 0.04 seconds, right? So now you now take your EKG. You say, okay, if I ask you, what is the PR interval? the PR interval is functionally a representative of how long it took for the impulse to travel from the SA node to the AD node. And that is measured on the EKG by the beginning of the P wave to the beginning of the Q wave, PR interval. And normal PR interval is 0.2 seconds. Do you need to really measure 0.2 seconds? No. Once you look at the EKG, the P wave and the beginning of the QRS must fit within one big box. If the beginning of the P wave and the beginning of the QRS extend beyond one big box, PR is prolonged. Okay? Now, the QRS duration is a measurement of the ventricular depolarization. So the QRS duration tells you how long is it taking the ventricles to depolarize. And usually there should be 3 small squares. 1, 2, 3. Right? Or 0.12 seconds. Okay? So the QRS should occupy about half the big box. Right? And the PR interval should occupy the entire big box. You shouldn't go past it. That is how I want you to think about it. Excellent. And then you see the QT interval, which means the beginning of Q wave to the end of T wave. QT interval should never be more than 2 big boxes. Okay? Which is 0.4 seconds. Alright? So that is as far as time signature is concerned. Okay? So what is normal PR interval? 1 big box. What is normal QRS duration? 3 small squares. Or 0.12 seconds or 0.2 seconds. Right? Good. And when you're looking at an EKG, you're looking at QRS, it should occupy about half the big box. So that is why we do this for time. And then for voltages, because we want to be able to measure the amplitude as well. For the voltage, 2 big boxes correspond to 1 millivolt. 1 big box equals 0.5 millivolt. This one you need to be careful, because you see this you can't change. The paper on all EKG machine travels at 25 millimeters per second. But the machine, the person that is doing the EKG, can decide to make 1 millivolt 1 big box or 1 millivolt 2 big boxes, depending. If the patient has massive LVH and the voltages are riding over themselves, the waves are riding over themselves because the voltages are huge, you can decrease the amplitude by changing the calibration to make 1 big box 1 millivolt. But if the voltages are normal, you will leave it alone at 2 big boxes for 1 millivolt. That is all I needed to know about this one. The most important information on this slide is really the time signatures. Okay? And I will also let you know how we go about that. So look at an EKG, right? From the beginning of P wave to the end of P wave is actually the P wave. But whenever you put the segment, the PR segment, with the wave, it becomes a PR interval, right? So you have a P wave, then you have the PR segment, that is the portion of the wave between the end of P and the beginning of Q. It's called PR, even though you measure it at Q. If you find a Q, you measure it at the beginning of Q. If you find an R, you measure it at the beginning of R. But generally, you don't call it PQ. Even when you're measuring it between end of P and the beginning of Q, you still call it a PR interval. Okay? The P wave and the PR interval together, when you include the PR interval with the P wave, you actually call the PR interval. Please don't get confused. The P wave is the P wave. This is the PR interval. Whenever the wave includes a segment, it becomes an interval. When you have a collection of waves, it's called a complex. Okay? So remember I told you that PR interval is usually no more than 0.2 seconds, which is one big box. Right? Look at the QRS, usually less than 0.10 seconds, three small squares like I told you. Look at the QT interval, generally less than two big boxes, less than 0.38 precisely. Right? And on the EKG, this is how it looks. You have the P wave, you have the PR segment, you have the PR interval, you have the QRS, then you have the ST segment, the distance between the end of the S wave and the beginning of the T wave is called the ST segment, and then you have the T wave. And sometimes you can get this U wave. They are not common, but when there is hypokalemia, you can find U wave. But generally we don't have U waves. Just know that they represent the Purkinje fiber repolarization. They are not on standard EKG. They become prominent sometimes when T wave is flat, and they become prominent U waves in hypokalemia. All right? So please pay attention to my notes. Segments, PR and ST, unlike intervals, do not include waves. So if you're going to measure the end of P to the beginning of T, you're going to call that PR segment. If you are going to include P wave in it, you're going to call it PR interval. If you are going to include the ST segment, you call it ST segment. If you are going to include the T wave, you call it QT segment, a QT interval. Okay, so intervals always include waves and segments. When you take out the waves, you're left with segments.
Can I just ask why it's the PR interval ends at the start of Q?
Yeah, because like I told you, even though the complex is QRS, you don't always see all the three of them. The one that you see the most is the R wave. As a matter of fact, whenever you see Q wave, you have to make sure it's not a pathologic Q wave. So Q waves are not common. R wave are the commoner one. That's what we call it PR. All right?
Dr. Martin?
Yes.
Just a quick question. So for the QT interval, it has multiple waves in there. Shouldn't it be a complex?
No. For the you say QT interval?
Yeah, QT interval.
Yeah, QT is usually measured from the end of Q to the end of T. It consists of Q, an ST segment, and a T wave.
Okay.
That's why it's an interval. An interval always includes wave and segment. Complex consists of multiple waves without intervening segments. Okay?
Why did a QT, like you just like Q waves are not common? Why is it like converged?
It has to do with the sensitivity of the leads and what is going on in the myocardium. You'll understand that when we start talking about a dead myocardium present on the EKG as a Q wave. So the Q waves are common when the myocardium is dead in that area, right? Under normal circumstances, you see Q waves, but they are not more common than R waves. R waves is in every lead, even when it is small, it is still present. Okay, you'll understand these details later on.
Dr. Martin, I'm sorry, I used to think U wave was the Purkinje fibers.
U wave,
Okay.
U wave, they represent Purkinje fiber repolarization. They are not normally seen on EKGs, only when there is hypokalemia. When the amplitude of T wave is suppressed, then they become prominent. Okay? All right. Remember I told you that depending on the size of the voltage, you can decide to make one big box, 1 millivolt, or two big boxes, 2 millivolt. How do you know what the EKG machine is doing? At the beginning of every recording on the EKG, you will see this thing. That is the calibration. It's a calibration box. If it spans two big boxes, that means standard calibration. That the EKG is recorded with two big boxes equaling 1 millivolt. If you see it span only one big box, that means the calibration is 1 millivolt for one small box. Sometimes the voltages are so small that you can actually make 4 big boxes 1 millivolt. When that is the case, you will see it here. So at the beginning of every EKG, there is this voltage calibration. So you should look for it. Usually it should be 2 big boxes to 1 millivolt. All right? I'm going to stop here. But before I leave, I want to say this. At the end of this class, you will be very comfortable with interpreting EKG. But please, you're all going to follow this thing called ROEs. You will not find it in any textbook. I came up with this. And the reason I came up with it was because when I left residency, did cardiology rotation, nobody could make it easy for me to understand EKG without sweating. They all want to start with rate and rhythm, and I needed a way to be able to look at an EKG and with a template in my mind, go through the EKG without missing anything. And this right here, I left medical school in 1989. I don't know how many of you were born then. But this right here has really helped me all through my career. If you will carry this in your heart as we go through EKG, just remember ROEs. If you will carry it in your heart, whenever anybody listening to you interpreting EKG, they will recognize you as a Drew graduate. Because there are 2 things I will teach you that only you will know. And whenever you talk about it, people will challenge you. But don't tell them why you did the way you did it. That is our secret ingredient. So whenever you look at an EKG, the first thing you should look at is the axis. You say, oh, this EKG has a normal axis. Then you should determine the rate. Tell them about the rhythm. Talk about something called orientation. And then pay attention to the waves. Look at the intervals and look at the segments. And in that order, you will interpret the EKG. Even if right bundle branch block is jumping at you, you will disregard it until you get to the wave section of ROEs. Even if ST segment is screaming at you from the EKG, you will disregard that ST segment elevation and go through the template of ROEs. Axis, rate, rhythm, orientation, waves, intervals, and segments. Why is this important? Because sometimes you will get distracted by what is so obvious that you will miss a more deadly EKG features that may be very silent. If you don't have a template that you use to read the EKG, you're going to fall victim into that trap. And I don't want you to ever fall victim into that trap. That's extremely important. In our next class, which I will have more time, and it's a good thing, because then I will finish the slides and we'll go through a lot of EKG. This is just to lay the groundwork. Everything I have taught you this morning is aimed at you understanding how to interpret EKG. Don't waste your time trying to go back to study instantaneous vector and intervening triangle. And the whole point of all of that intervening triangle augmentation is for you to know that we did all that to be able to put the heart in the center of a circle and build quadrants around it so we can determine the axis. That's it. If you know how to determine the axis and you understand how we got to where we are, you don't need those other details. I gave it to you because it's important for you to understand that. So when I say what is the axis, I'm not giving you a shortcut on, oh, it's negative in 1 and AVF, therefore it's indeterminate. No. I needed to know, yes, in practice, that's how you would determine it, But there is a reason why it is like that. And if somebody take you up on it, you can explain to them to the best of your ability. Okay? Any question? Good. We'll finish next Monday. Oh, next Monday is a holiday, right?
No.
All right. Okay, we'll finish next Monday.
You can make it a holiday.
I wish. Wish I could.
That was rough. That was rough. That was a lot.
Yo.
What I feel like the whole day was just gone right now.
I couldn't believe it was already 11 when I looked at the time. Shit.
Oh, man.
Yeah.
Do you like have to
I do. I have to put it on my. No, I mean,